This is one of my favorite topics these days. Recently, about 5 years ago, I became a grandfather, and then a second time a couple of years ago. And this is the thing that worries me most is listening to what Nora was talking about yesterday, that, just thinking about those 600 fewer sunsets hit home. So this conversation here, about maybe 10 years ago, if we were having this conversation as food as medicine, and if the word woo-woo was in vogue, we would have said, oh, this is all woo-woo, right? But now nobody thinks that food as medicine is woo-woo, but we're still struggling. We got to figure out how do we actually make food medicine, and it ties in with sustainability, it ties in with how we can afford it, et cetera, et cetera, et cetera. So that's the conversation we're about to have in this panel, and then we'll follow up in the second one as well. As usual, we'll do our initial introductions. We'll start with you, Megan, and then we'll go over. Go ahead.
Sure. Hi, everyone. My name is Meghan Reed. I am the clinical nutrition manager at Northwell's Lenox Hill Hospital. For the last 9 years, I was a clinical dietitian there, and over the last year, stepped into the clinical nutrition management role, where I've had a lot more opportunities to work within our food as health program, working at the system level with our community-based partnerships and with some of our more national level partnerships, and then also working at our site levels, working with the hospitals individually based on the resources that they have and then what their patients are really needing.
Awesome.
Hi, good afternoon, everyone. My name is Kelly Naranjo, and I'm the manager of research and evaluation at God's Love We Deliver. We are the only medically tailored meal provider who's a nonprofit serving the New York State area. I also am part of the Food as Medicine Coalition, who's a coalition also of medically tailored meal providers and medically grocery providers across the country. So just as Megan mentioned, we do have a lot of partnerships within New York State with payers and hospital systems and academics. And during the last 2 years, I've been leading a lot of our academic partnerships. And I also work in conjunction with the rest of our team to evaluate our healthcare contracts, some of our philanthropic programs. And my background is actually in academic medicine. So just I've taken all that knowledge of running clinical trials and running NIH studies and population studies to bring that back to our community-based organizations. So basically, our research focus is clients at the center. We've done a lot of work to sort of raise their voices nationally. And we actually have our first clinical trial now funded through the American Heart Association Food as Medicine Initiative. We're partnering with the Columbia Mailman School of Public Health for that. Happy to be here.
RJ.
Hey, RJ Briscione, thanks for having me. I am a principal at Health Management Associates, HMA. HMA is a roughly 900-person consultancy with folks just about everywhere in the country, all the big state capitals, all the big cities. I'm based in Atlanta. I work with a team that's just about everywhere. My background is, we had a fun background switch last panel. I'll give you another good one. Here's a great natural progression. 10 years at Delta Airlines, about 3 or 4 years in politics, mostly at the state level. And then now 15 years in healthcare, most of that from the payer side. So spent 15 years with Medicaid plans at Centene, Anthem, and Aetna, really being a P&L leader. So being kind of the CEO in charge of the large Medicaid plan budgets within a state, and then building those Medicaid plans, working with states. How do we go get new plans in new states? How do we renew our contracts? And while I was doing that, there was an insight that it was unlocked. This was probably 2017, in that we don't exist as health plans without the state Medicaid directors, without the state Medicaids. And they started asking about social determinants of health, and we didn't have any good answers. And so I sort of internally founded and internally pitched social determinants of health at Aetna, and then ran that for about 4 years across CBS, and then became part of CBS in about 2018, and then moved into consulting about 2 years ago. A lot of my practice now is working with nonprofits, actually. So we work with Feeding America. I spend a good amount of my time on Feeding America on how do they bring that, everything that they have and they can offer, not just the food, but the what is going on with those patients, what is going on with those members, to payers and to providers. So what's their strategy? What's their go-to-market on that? And then we've worked with lots of, there's actually interest in this. So you said you were, wanting to know the interest of it. There's private market interest in it too. So we've worked with buyers and sellers of some of the platforms available for food as medicine as it becomes a real thing. So very excited to be here to talk about this. This is my favorite subject.
Nice. I love the transition story, and just to have a little fun with it, as if you put your payer hat back on, and we said food is medicine, when do we get reimbursed for bananas?
Yeah.
Right. That's the big question.
Yeah, that's right. Yeah.
So and to begin the conversation, maybe RJ, you
Sure.
can jump in from your side and say, when did food as medicine switch from being quote woo woo, let's say many
Yeah.
years ago, to where it really sits today? And is it more platitudes, or is there reality in paying for food to determine health, really?
Yeah, there's a few things. I'll go down the continuum a little bit. I don't want to take everybody's time, but there's a couple ways of doing it that have gotten really well proven. So the medically tailored meals, I think people are most familiar with. That again, they have real results. They have real clinical trials, right? And so there's a lot of payment mechanisms that would allow for those to be done, and most folks are pretty understanding of that. There's a couple more nascent areas. I actually serve on the steering committee for the National Produce Prescription Collaborative. We just in December submitted an application for HCPCS code for produce prescription.
Really?
Yeah.
Oh,
Yeah.
man, that's
breaking-
big news. So,
Semi-breaking news.
Yeah,
Yes.
yeah.
Yeah. I was actually in my update email this morning. I'm glad they emailed that this morning. So obviously a long and arduous process for that, right? So there's produce prescription. And then there's another category that we're seeing, and I saw a lot of this when I was at CVS and doing research. There is an understanding like what was going on with our Medicaid members living their real lives. There's a really big need for being able to supplement food that equals, you mentioned food is health. I had an invite to something else. I got it this morning. It's for later in the month or next month that, I think people are trying to switch the food as medicine to food as health. And that is, if you think about the average life of somebody on Medicaid, what their budget needs are and what their calorie and macro needs are not being met in a regular Medicaid world, right? And so what can we provide for that? So there's some really cool solutions coming up for that, where it can be preloaded on cards and so that the categories are somewhat restricted. Instacart is actually doing a really interesting job of partnering with health systems, with health plans on doing that. So that kind of falls in the category of the like supplemental nutrition, but in a real way that we can measure the outcome of how much better is that person, either from a quality perspective or a cost perspective. I think that's an opportunity for the future. And then there's you're probably more familiar with, there's a more willingness to pay. Interestingly, some of these things don't actually include the food, but things like Virta have been very successful for condition specific. So Virta's very specific for diabetes. They've now shifted into weight loss with the GLP-1 kind of craze as being a really good alternative to GLP-1s in a weight management program. But Virta's been very successful in clinically documenting. I have no connection to them. I'm just a big fan because they have really good results of reversing diabetes, right? And so in those condition-specific programs, there's ways to pay. The other couple of things I'll say, we work with especially the nonprofits, the Feeding Americas and the state associations of food banks, is where state Medicaids have created 1115 waivers that have specific payment paths for them. So California's done a great job of that. North Carolina's done a great job of that. Michigan's about to bring that online, very specific for food as medicine payment pathways for food. So
Nice.
I'll leave it there, but those are the ways to get paid now, with a bunch more in the pipeline. And then we can talk at like kind of administration policy. Maybe if they just say like states have at it, Medicaid is block granted, then maybe there's an opportunity and a path for this.
If Medicaid is around in a few years, is that what you're saying?
Yeah, exactly. Yeah.
Before we jump to the ladies,
Yeah.
one quick
Yeah.
note, just tell us, how would the HCPCS code work in practical terms? Do you guys know
One
about
of
the
y'all want to
adherence
take
code?
that? Or
Yeah.
Go ahead, please.
Yeah.
There's been a little bit of work. Actually, the initiative is called Code Food.
Yeah.
Mhm.
And so there's been a lot of presentations on it. So the codes, a couple of different codes for it, including medically tailored meals. And this is where things get like a little tricky and contentious because our definition as a nonprofit provider of medically tailored meals includes an RDN assessment. And obviously, and attest to this versus like maybe other definitions out there that include an RDN review menu. So there is a couple specific codes for medically tailored meals.
Differentiator between the two?
Whether you think about the RDN assessment
Mhm.
and medical nutrition therapy as being bundled into the intervention
Okay.
versus an RDN just overseeing the line per se.
Okay. So in this case, let's say Megan was our RDN. Let's pretend we have an RDN on stage. So how does that change? So in one case, she is pre-approving something, like let's say you have the codes. In one case, she would be helping to pre-approve, and the other case, she's directly involved in the prescription process itself?
Yeah.
Okay.
So in the nonprofit sort of intervention model, all of our clients that are coming into service are receiving an assessment with the RDN. And the RDN is gonna determine there isn't like a set diabetes menu because all of the meals are low sodium, heart healthy, no preservatives, low sugar, but they're gonna determine like, okay, can we abide to cultural preferences, or there any other specific preferences that you have, and then assess other social determinants of health, like do you have actually access to other benefits that you can supplement, or how in terms of like mobility, what are your mobility issues versus Megan just designing a menu. This is a diabetes menu and everyone who's coming in with diabetes gets this, or this is the renal menu and everyone renal gets this.
Mm-hmm.
So that's one big difference. And then secondly, this coding for food program right now, they have done the medically tailored meal process. They have convened a ton of stakeholders into deciding what's appropriate for a code. Now they're in the process of doing medically tailored groceries and sort of bringing their way down. And just to tie this into your earlier question about costs, well, it is a lot cheaper to feed someone the home delivered medically tailored meals than pay for hospitalization or for an ER visit. Yeah. And some of our previous analysis, like I also mentioned that we are engaged in healthcare contracting. For a lot of our payers, it is cheaper to pay for a year of the medically tailored meals with us than it is for like 2 days of ER visits or a hospitalization stay. And part of that is also tied into the work that we do for medically tailored meals. If you think about the food as medicine, like pyramid, we're at the top. So we're sort of using it as treatment and health preservation to prevent worse health outcomes. And as you go down with the groceries, with the produce prescriptions, food banks, it's sort of like you're going down in how sick someone is. But ultimately, there's huge cost savings in preserving that health, because once clients or members or patients reach a certain threshold, there's really no going back. And you're going to be spending more money in the long term than if you address someone with the medically tailored meals or the nutrition therapy or all of the other nutrition interventions.
Nice. So it turns out that then pretty soon bananas could be reimbursed. That's awesome.
Yeah, exactly. They can be in certain places. Yeah.
So Megan, talk a little bit about, so when you look today at meal plans and when you look at medically suggested meals, many of them are using prior research, which is fantastic. But today we do have the ability to do genetic-based counseling. We have the ability to do CGM-based counseling. Where does that fit in any of the work that you're doing today? Or is it mostly based on prior research at population levels? And how far can that really take you?
It really all depends with who you're working with. I think branching off what you're saying, having all of our meals and our medically tailored meals be individualized to all of our patients, that's why the medically tailored meals have been so beneficial to our patients, and that we're able to kind of use these individual approaches, having a dietitian on the staff at the medically tailored meals as God What We Deliver has. We're able to continue that education with our patients and keep individualizing based off their needs and using ideally the food to help manage these chronic conditions. So I think individualizing to our patients and making sure that we are getting them the resources based off what they specifically need is what's most important for these patients.
But how do you individualize? Because currently you only have population data, right? You only have individual data. I mean, you could have somebody's weight, blood pressure. You have other vitals. But how do you get to individualization without genetics, CGM, et cetera? How do you individualize then?
I think from more at our perspective, we're looking at how are we preventing these chronic conditions from worsening? How are we preventing malnutrition from worsening? And looking at, when I speak to individualization, even that patient's preferences, what resources does that patient have? We can absolutely go further into genetics, but from the dietitian perspective, right at baseline, we can't even get to that point if we can't even get the patient's food and
I
get
love
them
it.
eating
Yeah.
the proper food.
Yeah. So basically, the nice way of her saying, hey, dummy, there's a lot of stuff that can be done with just at the population level, get people's food to not be horrible. So it's not great, but at least not make it horrible. The thing that, and the reason why I brought up the question is that in programs, other programs that we've set up, year one, you can make a lot of you can accomplish quite a bit pretty quickly just by not doing dumb things, right? Which is basically what you're saying. It's a great advice. But as we look forward, one thing we've got to figure out is that very soon, it's like wellness from 5 or 10 years ago. People talk about it, then people start doing it, and then they realize some of this is woo-woo, some things are not. And then they're like, oh, this was all dumb, let's throw it all away. Like, that's what we don't want to happen. So so let's assume you look out a couple of years and you say, okay, we've stopped doing the dumb things, we're feeding them at the levels that they should. But really, is there more that you can get? And what would that look like using tech, software, genetics? The problem with genetics is we know how to collect the genetic data, of course, and we know how to generate the reports. You guys don't know how to read them yet. You probably do, but most other docs don't know how to read them to do things with it. So talk a little bit, maybe a year or two into the future. Let's assume this moves still forward. How do you get to true personalization, and how could folks like these help you?
I think a lot of it is going to be having the support to do that research. I think a lot of the work that we're doing now is based off of the funding that you have, the resources that you have, the support that you have. So a lot of that individualization based off genetics, like you're speaking to, is also going to take more education to the people that are going to be providing those services and making sure, like you said, that everyone understands what they're reading.
Right.
There's more research that's needed. There's resources needed for the providers that would be implementing all of that. So a year down the road, I think if there is the support behind it and the funding behind it to do more research studies, it really could get implemented and further these medically tailored meals and services that we're providing to our patients to make sure they're getting the food that's most appropriate for them to manage these chronic conditions.
And I kind of jested about Medicaid being around in a couple of years, but it's partially serious too. Remember, you guys can ask questions, pop in your questions anytime. But RJ, is anything about food as medicine or food as health politically motivated in terms of red states buy it and blue states don't, or vice versa?
Yes, and I think there's a potential change here. So like I will tell you this, one of the other groups I've worked with has been HHS at the federal level to build out a toolkit for states to see. What we've done is we were able to get to a lot of data and build that out from Medicaid data and from lots of other data sources on what is the prevalence of food insecurity in each state, so that each state has that available to them from HHS now. That was the first piece of the project we've done with them. They're still on board. That's housed in the Office of Disease Prevention at HHS. Those are the folks I work with there are non-political appointees, so they're still there as of this morning. So I checked with them. Will be interesting. One of them does not live in the DC area, so more to come on that. Which will be very interesting. Look, I'll answer the question a couple of ways. So far, up till 4 days ago, it had broken down mostly blue as to the states, because like this is inside baseball and nerddom, but this is how stuff happens. The 1115 waivers are really, really hard it's a painful process to do. It's just as painful as doing a bid for, I came up doing Medicaid bids. But even more so, the state has to, get resources. They've got to get funding just to write it. It probably costs a couple $1 million all in just to write it. You submit it to HHS, it sits there and waits. Then it comes back. Then you got to authorize it. Then you got to build out the, Michigan, Illinois. One of those is very blue. One of those is maybe slightly middle of the road. Are in the process of implementing now. So there's so much to do with the implementation of that. We've seen it carried out really well. The Food Bank Association of North Carolina, who's probably them in California are the most mature in this, have carried it out really well at where the state policy wanted it to be intended, so that the community-based organizations, the food banks that were already on the ground, can deliver those meals very specific, very condition specific as needed. That has built out and worked really well, and I think they'll be getting good data and good results back on that. And then, the future, I'm bullish on like taking RFK at his word that like he's big on food supply, food safety, food is health. I think there's opportunity in there to see where that goes.
Yeah.
And that will be a path to it. Like, a lot of the things he spent the time since he's been nominated talking about have been in this food is health. And there's avenue and policy levers available for it within HHS. So, yeah.
So what is the fear, if at all, from the big food industry, which so if we put regular produce and the plant-based, I don't think you're going to find any arguments because you're not putting anybody out of business. But if you start selecting foods that are not hyper-processed, that are not using, quote, big foods, you're gonna kill some sacred cows here.
Sure.
What are those sacred cows? And have you felt like anybody has given pressure or anything to try to protect any sacred cows, or is it way too early?
Too early.
And it won't happen for a few years.
Yeah, I think too early. I think if nothing, big companies. You mentioned this in the last panel. A lot of big companies are lining up to get in line, because they can see the writing. So if anything, they'll need to be nimble, I think, on that. But where this breaks down is, where this movement can gain steam. Actually, I'll give you a great example. We work with the Florida Association of Food Banks, right? Probably the one of, if not the reddest states right now. The path to the Florida Association of Food Banks being able to be reimbursed for Medicaid in Florida has kind of a full circle value play with Florida farmers, right? No red state elected official, state representative, state senator in Florida, they're not anti-farmer, right? And so there's a ton of opportunity there to do that food supply in a nutritious and delicious way, that can benefit folks in Medicaid, that can benefit Florida farmers. That's their, I think you'll see it breaking down on those levels where it gets really real, to be able to do that for what they can supply. And, it's probably going to look different. It's not, I love the NYC Health and Hospitals, the Plant Forward program. I'm very familiar with that. That's not going to happen in Florida, right? But they're going to be able to bring locally produced, locally raised if it's proteins, and so yeah. I think.
So what do you guys need? From a on the ground practitioner, you've got organizations that you're working with. What are the, not just IT systems, but what are the systems changes that you need to introduce food as a quote prescription? Because that's obviously not in anybody's software. It's not in any care plans, et cetera. Or are they? And what could guys like who you see in the audience help? We'll go with you first, and then Megan.
Yeah, sure. So I can start with everyone's favorite word, interoperability. And basically what we need is for there to be systems that speak to each other. And actually we are in a health system now. I've been doing a lot of work in the last year with NYU Langone and the Grossman School of Medicine, and God's Love exists in the EMR right now.
That's cool.
Which is really cool.
Yeah.
We have been able to build a smart set to get referrals for our maternal health project, and we're seeing a lot of really great outcomes. So it is possible, but it's a lot of work. And it's not, as Megan mentioned, it's not achievable unless we have specific funding to do this work, and even positions like mine don't necessarily exist in every nonprofit. That's one. Two, I think to answer your big question, we really need care for public good. Because I, had been working on a grant for the NIH, and one of this technology partners was like, "Oh yeah, our fee is going to be $11,000 a year." I'm like, "That's really cool, but we don't have that much money." And they were like, "Oh, okay, wow." And it doesn't seem like 11,000 is a lot, but the initial quote that I had gotten was 5,000 per month. So I think, there needs to be partnerships, key stakeholder partnerships for social good. Obviously, there's money to be made for everyone. That's too. And I think just to address like your previous comment about whether there is a political divide, in terms of the work that we've been doing with a coalition, we actually had two bills, one in the House, one in the Senate, and both had bipartisan support. And so now if you're thinking about the incoming health caucus, sort of the call to action is make America healthy again. I can totally get on board with that because it doesn't matter if you're, Democrat or Republican, you're still going to have really terrible health outcomes, except, more liberal voters might be looking for a way to help you get better. And I think, there's so many people that shy away from social services and investing in social services as if it's this kind of crazy evil, but there's also room for profits to be made. There's room for money to be saved. Like if we take anything from what happened at COVID, like our healthcare systems are overburdened. And there's certain things that we can do outside of the healthcare system, which again only accounts for 20% of health outcomes.
That's right.
I know I'm preaching to the choir, and like the connection of the social services to clinical continuum is a really important one. And even thinking about what other panelists were discussing in terms of trust, like community-based organizations have already built that trust with communities. So this is the best way for you to have sustainable outcomes. But, don't charge us like $5,000 or $11,000 a year. Like we can't afford that. So it's not going to be possible.
Yeah. So speaking of those community support, what have you seen in New York with their 1115 waiver and the NYHER program with the social care networks?
So
specifically for food, I mean.
Yeah. So we had really big hopes that, there would be like a single platform for the social care networks, and there's 8. So for New York City specifically, there's 3. And so what we're seeing for us is like our team members have to attend so many meetings every single day because there's a referring platform for Manhattan, Brooklyn, and Queens. There's a different one for the Bronx, a different one for
Can
Staten.
you name some of those names just so people know what you mean by the platform?
Yeah, so it's Unite Us, findhelp.org, and to be honest, I forgot the one for Staten Island because I'd never heard of it before they got the contract. And so I'm not sure. And so what makes it really difficult is that when you are engaging with these different platforms, we do have as an organization capacity to have users in every platform, but you're also going to have an issue of what happens if someone moves from Manhattan to Staten Island. Yeah. Like they fall off the board. And there is really, in terms of like our systems, we're using Salesforce. So there are certain implementations. United is a really great one with Salesforce so that we can have, pre-charts into our inbox and we can just work through all of the information that we have without making less mistakes. But that doesn't really exist for findhelp.org. And it doesn't really exist for the other platform that I mentioned, and not to mention, the other platforms that are happening in the rest of New York State.
But do they know about food?
Yeah.
In the platform? Okay, so that's good.
Yeah. They know about food. It's like transportation as well. There is housing. So all of, social determinants of health are addressed through the waiver. It's just the problem is in terms of like what happens when someone moves. And then also we have God's Love has the capacity to engage in care navigation and billing. So that's really great for us. And obviously there's certain constraints in whether we can navigate clients to ourselves versus others, and that's fine. But unfortunately, like not every organization has this, and not every client is going to need the medically tailored meals. Like some of them might need, the medically tailored groceries or the produce prescription or the food bank, but all of those other organizations, like in speaking with some of them, like they're not ready for dealing with like 15 different referral systems because there's people that we're going to lose while we're trying to process.
Great. And as we move from the organizational level down to you as a practitioner, what does your day look like in terms of working with people in all 3 areas, the food itself or produce or the meals? What does your systems world look like? And what would you wish you had from systems providers to assist?
I think it really does branch off what you were saying about partnerships, just at a smaller level. we have so many referrals we're making, whether it's for the medically tailored meals, whether it's for medically tailored groceries. We actually are working on a partnership with Instacart, and I'm creating
Yeah.
a storefront
Yeah.
for patients to shop from, where it is geared towards heart health, and they can shop from this storefront knowing all of the items within it are already compliant with their therapeutic diet.
So hang on a second. As a dietitian, you're now building e-commerce platforms. Is that what you're saying?
Yeah.
It was a process,
One,
but
I'm very
yes.
impressed. But two, please go on.
Yes, but as you're saying, it's a wonderful benefit to our
Yeah,
patients and
yeah.
can be incredibly a huge asset, but getting them these resources, there's so few of us. So making sure that we're partnering with social work, that they can also make these referrals. We are making sure that our outpatient providers and partners have access to these referral platforms. We've built a platform, a portal within God's Love We Deliver, where other sites can also provide referrals. We are trying to make sure that we're spreading the education of all of the resources that we have so that we can reach as many patients as possible, because they all deserve to have these resources. It's just getting it to them.
Mhm. And so as you think about when you work with patients themselves, what is their reaction like? Are they like, why are you asking me what I eat? Or is it like, finally somebody's asking me what I eat? Where does most patients fit?
Runs the gamut.
Okay.
You get everybody, but you really need to meet the patients where they are. If they aren't overly enthusiastic, start smaller, really small steps that they can change and incorporate into what they are already used to, versus the patient who is so enthusiastic, wants every resource. I think that's something we work on in the hospital with our patient menu, is using that as a tool, because then maybe you're not ready for these massive changes, but you can look at the menu and say, oh, they served me beef stew on my heart healthy diet. That is something that I can incorporate at home. That feels doable, because as we were speaking about in the previous discussion, incorporating more of a plant forward menu, we're able to get those items to our patients and they enjoy them and realize, oh, I actually can do this. It's not a massive change. So running the gamut of the patients you speak to, kind of working with everyone and what's going to be feasible for them.
Yeah, and so we'll ask one series of questions, and all three of you can answer. One is, where are things breaking down? Like, all this sounds really good, and I think we're excited about it, but where is it breaking down? Like, where is it not really working at the individual patient level? And then you can answer at the partners and organizational level, and you can answer at the macro and across state level. So go ahead.
I think our biggest struggle right now with breakdown has been the transitions of care and making sure patients aren't falling through. And there's patients who we want to provide them with medically tailored meals, but they are not going home right after. They're going to a rehab after their stay in the hospital. So how are we catching those patients? And we're trying to come up with tricky ways where we can maybe start the referral process and then pass it off to the dietitian at the rehab or something like that, or having our outpatient partners have access to referrals and codes for all of our different resources, so that, okay, the patient wasn't ready inpatient, but they can continue that care for them. So transitions of care is kind of where we're working to make sure none of our patients fall through and there's continuity.
And is that so? If you try to fix transitions of care, is that an organizational problem, or is it a lack of software or systems or technology, something like that?
Probably both. I think we're working on various work groups within the health system to make sure that at a system level, we are coming up with processes where we can close those gaps that we're missing. But then also working on the different software platforms. I know God's Love We Deliver is working on a new platform where we could maybe kind of close those gaps as well. So it could benefit on all sides.
Okay, great. Now, at the organizational level, and one thing I'd love for you to bring in is, especially yesterday, we had one speaker, Nora, who mentioned that, I can't remember what the total percentage was, a big giant percentage of kids get their at least one or two meals from schools. So at the organizational and community level, talk about where you have big challenges. And are schools a challenge because they're not participating and they won't, or will they participate as well?
Yeah, so currently at God's Love, we serve clients with over 400 different diagnoses. So we have two pathways. We have our philanthropic pathway, and we usually fund these meals with like state grants and foundation grants. And then we have our healthcare contracting, and those are specifically funded with payers.
And what's the percentage breakout?
It's about like 55-45. we're like closing the gap, which is actually really great for us, and we're very innovative in that way. But
By the way, that number should be 100% coming from commercial
Yeah.
and no donations required.
yeah, it's true, but we're not, as a country, we're not there yet, but hopefully soon. But we have two different sort of breakdowns in the system. So if you're thinking about our philanthropic clients, the breakdown is in terms of education, right? They're not receiving nutrition education, and sometimes we graduate them from the program. They have to do a referral process, and they have to certify once a year. And sometimes that happens, sometimes doesn't happen, because there is, once again, trust. There's like less of trust between these clients and the healthcare practitioners. So they're more like a revolving
Where
door
was the lack of trust?
between some of our clients and their healthcare team.
You mean the client is who is the
Is the
client in
patient.
this case?
The client as a patient.
The patient themselves is not being trusted by,
No.
No.
The patient themselves is not trusting
they are not trusting
their
the
clinician.
the
and
clinician.
The clinician is telling them
Got
to
it,
do.
got it.
So, they get worse, and then we get a referral from the clinician, and they're like, okay, they really need the meals. So, the client / patient does better, and it leaves, a revolving door. We don't hear from them until they do worse again. So there's that big gap there that, as a country, as a state, we need to do better in terms of how can we improve this. And we've heard a lot of really awesome solutions today. Like one pathway, could be increasing the time that clinicians can spend, with their patients. So that's one. Secondly, within our healthcare contracts, I think it's a different kind of thing, because we are engaging our clients through value-based payments in lieu of service and managed long-term care. So that is great. I think the breakdown is in terms of like how long these interventions can be given to clients / patients / members. So sometimes we get, 6 months, and that's well enough to keep someone off hospitalizations for a month. But I think we are waiting for the connection. Currently, with one of our projects, actually, we're working on graduating people from the medical tailor meals, or having like the nutrition classes, cooking demonstrations, into groceries, and then just seeing them into real life. So the breakdown is more about transition them from like one end of the spectrum into another, because there's a little bit more opportunity. Our healthcare contract clients are, high healthcare utilizers, but they're not terrible. Like our philanthropic clients are not doing so great because they meet a certain eligibility to enroll into the services. So we have these two types of breakdowns, and it's really difficult, because again, we need investment for us to be able to save money longer term. And so, yeah, and it depends. And then the last thing I'll mention is majority of our clients, I would say probably about 60% of them, are seniors. And so they're coming in with multiple comorbidities, 4 or 5. And so the breakdown for them, it's because they are on a set income. They're having to make the choice. Do I buy the healthy food, or do I buy my medication? And oftentimes there isn't enough money for both. And so they do worse. And then, they end up at the hospital with Meghan, and they're like malnourished. And then instead of being, released to their home, they're being released to long-term care facilities where they might do worse and cost more money. And so part of the work that we have been doing very closely is for the people who have been recently admitted, let's make sure they have the meal so they can be released to their home as opposed to a healthcare facility. But yeah, there's so many little holes to poke. I think those are the big answers. Yeah.
He's right. She
Yeah.
got it all.
Yeah. But RJ, you've got the answers, right? A bunch of
Sure.
policy shifts here and there.
Yeah, there are. So kidding aside, on the macro level, those are the issues, right? All of those are the issues. It is, but we always say when we're talking to clients, especially in the Medicaid world, you describe some really cool things, like almost nobody else is doing food and value-based care right now. That because it's New York, right? So New York and California and a little bit of North Carolina, you could do that. You can't do that anywhere else, right? And so
Due to lack of value-based care, or
due
just
to
something
the
else?
lack of anybody's ability to actually, like, you don't have to convince most CMOs at a Medicaid health plan that this is the right thing to do, right? Like, there was a time, to your much earlier question of like, oh, I don't know if we can get the ROI on that, right? Like most people know that now, and there's been some great, like Geisinger's done a great job in Pennsylvania. They have this the healthy pharmacy. They published on a 2-to-1 ROI on diabetic patients, like $200,000 a year saved per patient. Incredible, right? Not surprising to most people who would follow that, but there's no, in most states, you can't get that into the M of the MLR for a Medicaid health plan, which is where I lived for years, trying to balance a 2 or 3% margin budget. You just don't have it. And so that is the bigger issue. The other issue is exactly as she said, like the transitions, you may have heard this stat, but the average, and it's about to get a lot worse to your policy point, the average tenure of a member on a Medicaid plan is like less than 8 months. So if I'm that CMO and I want to bring all this food on, that person's not there to get the ROI. We lose them. We can't find them. This is what I did, kind of inside of a health plan operations, right? So then it becomes the like wrong pockets problem, because hey, if I only got that patient for 8 months, I don't see the ROI on that. For ideally you want them a year, 18 months plus, to be able to do that. So there's a couple of those things stacked on top. As I talked about earlier, I think there's potential policy relief on the way. Ideally, 1115s either get easier or, it sounds silly, but like if you're going to block grant everything, and there's people that can take up the slack and say, we can make this work in the state, and we've been working with a lot of folks on that, like the food banks, the community-based organizations are ready to engage and ability to deliver that. I think there's hope there for that.
So traditionally, Republican administrations in the past have liked the idea of block grants because obviously it gives states more power. Do you feel like this Republican group is similar to the past Republican group from what you've heard?
I think so. That seems to be where they might head, but
All
right, we'll wait and see. But I think first, I am concerned. You asked, some of the other panels about what concerns are. I am very concerned about, limiting Medicaid eligibility and how many people are going to be eligible for Medicaid, and then where they fall, because then where they fall is into the front end of the programs that she was speaking about, that she then has to fund with philanthropic, right? Because they're not going to be buying a marketplace plan, right?
Yeah, that makes sense.
Yeah.
Great. So we are, did we have a question? Oh, we do have a question, and then we'll finish up. Go ahead.
Just a follow-up, a tough question. You said 8 months, right, with Medicaid, but not for the populations that might use food as medicine, right? So I don't think it's fair to kind of put that together.
No, that's fair. The first thing I ran, I selected when I was at the health plan, was I selected duals on purpose. I knew I was going to have them around longer. So duals, people dually eligible for Medicare, Medicaid, selected a population that was both had identified at an FQHC partner that was food insecure and diabetic. We did all the things, right? A little bit of education, a little bit of kind of guided shopping at something that the food bank brought to the clinic. Had them test A1Cs all along the way